welcome everyone. My name is Rebecca Dekker. I'm the host of the Evidence-Based Birth podcast and researcher here at EBB. Morgan, do you want to introduce yourself as well?
Sure, yeah. Hi, everyone. My name is Morgan Richardson Cayama. I am a PhD candidate studying public health at the University of South Florida College of Public Health, and I am the new EBB Research Fellow. So I will be the Research Fellow for this year, and happy to
And
be here.
many of you have already watched some of the videos with both myself and Morgan. So I have to give Morgan a lot of credit for helping put that presentation together for you. So, Morgan, do you want to take the first question? Okay, let's talk about the elephant in the room, the elephant in the womb, the elephant in the room. How often are we seeing pressure from obstetricians to induce?
This is a great question. So I haven't actually found much recent research on this topic, but there is some research from around the time that the ARRIVE trial was published and actually some earlier studies. And anecdotally, of course, we hear that tons of birthing people and birth workers are having this sort of push on them. But there was a study that explored this topic, maternity care experiences, and it was done in 2014, so it's a little bit older now, and it was with around 2,000 women in birthing people in Canada. And so around 16% of them in the study reported feeling pressured from a healthcare provider to have an induction. So this was like obviously a pre-arrive, and we can imagine that it's probably gone up since then. And among those who ended up having an induction, over half, like around 54%, said that they felt pressured into it. So that's telling.
So that's British Columbia in Canada.
Yeah.
Okay.
And then we have the most recent Listening to Mother study in California that was done with around 2,500 birthing people. And again, that was in 2016, so still pre-arrive. But in that sample, about 40% of participants said that their healthcare provider tried to induce their labor. And around 37% of those said that they didn't really have a medical reason for it. And there was actually more pressure for those who had planned a vaginal birth. They said they felt more pressure by their providers to have an induction. And again, more people who felt pressured went on to have an induction compared to those who weren't pressured. So about 30% of those who were pressured had an induction compared to only like 7% who weren't pressured chose to have an induction. And then there was like a smaller qualitative study that was done in Australia. I think we saw some people in Australia in the chat. And so they did interviews with some birthing people there, and they kind of wanted to hear about their shared decision making experiences related to their induction. And so some of the common themes that came out of this study were participants feeling like they were told they needed an induction rather than being given the choice, not feeling like they were given enough information about the induction or induction processes, and really not given enough information about the pros and cons of if they didn't choose to have an induction. And they also found that satisfaction with their induction experience was really related to their general openness towards having an induction in general. So if they felt like they were already, kind of more open to it, that they sort of trusted their provider, that they kind of deferred to their provider to make that decision, then they were more satisfied with that experience versus people who felt like they wanted more of a choice and they wanted sort of more of that shared decision making role were less satisfied with their induction. And yeah, so that's about all the research we've seen so far on pressure. But again, anecdotally, we're hearing a lot from people that this is happening.
Yeah. And you mentioned in your part of video 3 that coercing someone into an induction is considered mistreatment in maternity care by researchers. So hopefully, as mistreatment becomes a bigger research topic and there's more funding around that, we'll see more data on pressure and coercion. So, do you want to ask me the question that's right underneath it? Because it's related.
Sure. So, how can a birthing person manage pressure from an obstetrician to get an induction at 39 weeks?
Yeah, I think one of the things that came up in the pro member training when we did a private showing for them, we had a discussion about how, sometimes you hear you should be induced at 39 weeks and they'll give a medical reason or they'll say because of the ARRIVE trial, but sometimes they just say because, and then the patient assumes that there's a medical reason. So it's almost like you think because a doctor's recommending it that it's medically necessary. Because why would they recommend something that's not necessary? And so that's one thing, is to find out what's the actual reason they're recommending an induction. Um, and I think I'm actually going to I'm using my induction pocket guide because it has a page on this. about how to manage pressure. So the most important thing to know is that you have options. So if you're told you need to have an induction or that an induction is recommended, most people just assume they have to do as they're told, but you have the right to ask questions. You have the right to have those questions answered with accurate information. You have the right to say yes. You have the right to say no without being pressured. And if you say yes to an induction, you have the right to help decide which methods will be used. So I think for me, that's always been an important teaching point is to just explain that you do have options. You don't have to just do whatever you're told. And um, I have questions that I would ask. I would say, what's the medical reason for this induction? What do the professional guidelines say about inducing for this specific reason? If they say it's because of the Arrive trial, I would say, well, what do your professional guidelines state about induction, elective induction at 39 weeks? And hint, hint, it does not say you should always be induced. Um, and then if you're really thinking about considering an induction, how ripe is my cervix? What is my Bishop score? What are your preferred methods for cervical ripening? What options do I have to prepare for this induction? And then you can even go further back. Many of you birth workers may know this. There are certain providers that always recommend an induction. So that would be very useful info to know earlier in pregnancy. So I like to help parents ask questions earlier in pregnancy, such as what is the induction rate in your practice? Out of the last 10 births that you did, how many were induced labors? And also, what is your cesarean rate with inductions? Out of the last 10 inductions that you did, how many of them ended in cesareans? So you can ask those questions early to find out what their practice patterns are. And I think a lot of parents are just kind of blindsided by this in the third trimester, and they did not realize that this was a thing. So, the more we can do to educate people that there are certain practices out there that are pressuring people into inductions and that they know that this discussion is coming, then they can prepare for it with the evidence. But know that you have options. And also, I think induction at 39 weeks for elective reasons is it can also be considered evidence-based because the evidence does not show it's dangerous. If it's something you want, it's a good option, but it should not be across the board. Everybody has to have this. So that's how I would answer that. I don't know if you have any thoughts to add, Morgan.
No, that was great.
Okay, I'm gonna see if there's any. I think it's an important question. So those are the two I wanted to start off with. Molly, have an addendum to your birth plan, expectations for care if induction is part of my birth experience. Exactly. So coming up with one. Yeah, a lot of good discussion and supportive comments in the chat. That's great. Okay. So let me pick one for you. Speaking of the Arrive trial and its outcomes, because it's often used as the reason for justifying. And I can't remember if I have a poll question on that or not. Let me see. Oh, can you answer this poll for those of you who are here live? Have you ever heard of a care provider saying you should be induced at 39 weeks because of research showing better outcomes for babies? And I'm talking about elective, not for preeclampsia or something like that. So go ahead and answer that question. And then true absolute risk reduction with cesareans from the Arrive trial. So some people get confused between relative risk and absolute risk. Relative risk is the risk of something happening to you in comparison to something else. So the absolute risk is the absolute chance, the actual chance something might happen to you. So the absolute risk in the Arrive trial, induction dropped the cesarean rate from 22% to 19%. So it was a 3% total reduction. But the relative risk, sometimes doctors will say the risk of cesarean was 16% lower. If you do the math, a decrease from a 22 to a 19 out of 100 is like a 16% chance, relative chance, but it's a complicated math equation to get to that number, and it doesn't really make sense in people's minds. So really it's better to give the actual numbers, which is a drop from 22% to 19%. But again, we covered in the videos that that is not necessarily going to happen in every hospital that implements the Arrive study. So I'll go ahead and see. You should be induced at 39 weeks. So because of the research showing better outcomes for babies, 71% said yes. That's pretty high. Morgan.
Yes.
Okay. I'm looking for geographic trends. So I know we covered that a little
Yes.
bit in the video. I think that's number 9 on our question list.
Yes, it is. So 39 week elective inductions are what we're seeing more common in the US compared to many other countries. And we did talk a little bit about that in the videos because other countries haven't really kind of hopped on the bandwagon of sort of routinely recommending 39-week elective inductions. And usually they prefer to wait, like sort of recommend waiting until 41 or 42 weeks. And then inductions at that point are often done because the pregnancy is reached like post term, or there are other health issues like gestational diabetes or high blood pressure during pregnancy. And elective induction rates themselves can vary pretty significantly from state to state in the US. And I'm sure that's probably similar in other countries, depending on the area you're in and the hospital you're in. But data are really difficult to find. And I did try to find research on this, but inductions tend not to be reported accurately on birth certificates, which is like one of the biggest sources of this information because they're just not captured. They're not really reporting for sure if it's an induction. That's like one of the outcomes that isn't reported very accurately. We've heard of rates like as low as 10%, but as high as like 40, 50% plus. So yeah, this is just kind of a question for chat too. Is like, what trends, and you kind of talked about this before, but what trends, are you seeing in your area? And, if you had to guess. And again, that's also going to vary provider to provider. Like Dr. Dekker said, that's a conversation to have with your provider as well. There's a lot of variables and a lot of things that impact that.
Yeah. Do you want to go to question number 2 then, since that's kind of related to what we're talking about? And some people are asking about that in the chat too.
Yeah, sure. Just a trigger warning for this question. We are going to be talking about some statistics on, infant death and mortality. And so a stillbirth is the death of a baby after 20 weeks of pregnancy, just to kind of throw out some definitions. And they can be defined as early, so that's like between 20 and 27 weeks, late, which would be 28 to 36 weeks, or term, more than 37 weeks. And the rate of stillbirths in the US actually went down a lot in the 1990s and early 2000s, then went up a little bit again in the 2010s. But since then, it's been about the same. And it was like around 5.8 infant deaths per 1,000 births in 2020. That's how we measure it, is like per 1,000 births. But I mean, the rate hasn't changed much in the years before or after the ARRIVE trial. And I also looked at some of the more recent data for perinatal and early newborn deaths, and there also hasn't been much of a change. So perinatal deaths are the death of a fetus after 28 weeks, or an infant death younger than 7 days. And so the rate in 2020 was about 5.6 deaths per 1,000 live births, and in 2021 was 5.5 deaths, so not much of a change. Early newborn deaths include, again, the death of an infant within the first 7 days, and those decreased by about like 4% between 2020 and 2021. But overall, like a lot of the stuff that you'll say just says it's like been pretty much the same for the last like decade or so. We haven't seen much movement either way, pre or post ARRIVE trial. So
And 4% is the relative risk. So the absolute risk reduction is smaller.
Yes, correct.
You had written 2.86 per 1,000 births versus 2.75 per 1,000 births. So roughly the same.
Correct.
Yeah. So
yeah.
And the ARRIVE trial, as we talked about in the videos, did not find difference in the primary outcome for a couple of reasons. One, because stillbirth is pretty rare. They had about 6,000 participants, but you would need way more than that to see any kind of a difference. Theoretically, though, it could prevent a stillbirth in a rare scenario. So you would need a huge research study to actually have those numbers play out. I think we talked about stillbirth prevention on the EBB podcast episode. It was about Count the Kicks, 243, the importance of kick counts for preventing stillbirth. And there's a lot of resources in that article about evidence-based ways to lower the chances of stillbirth. So induction is not the only way. Other questions? You want to pick one out to ask me?
Sure. So this one's kind of interesting. What if a midwife or obstetrician refuses a 39-week elective induction? If you're a birthing person who wants it, but then they don't want to provide it.
Okay. So I hear this happening occasionally. In fact, I have a good friend who's a provider who does not do elective inductions for because that person provides continuity of care. So in a lot of practices, they rotate call, meaning they're kind of on a shift, an assigned shift to attend births in that happen in that 24 hours. And this particular provider that I'm thinking of provides continuity of care, which means she attends your birth no matter what. So she is not going to pass you off to somebody else. And as you all know from the videos, one of the problems with inductions is they can be very long and tedious. And so it's one thing if you're working shifts, but it's another if you are the provider for that patient and you have promised them you will be there at that birth and you're giving birth in a place where it's maybe they don't trust you in the hands of another provider while you're gone. So that provider in particular says, I don't do elective inductions. They're too hard on me. I'm a mom with small kids. I can't be at the hospital for that long. So she only does medically indicated inductions. So I would say if that's something you're interested in, is to find out earlier in pregnancy. And some people want an elective induction for social reasons, emotional reasons, other reasons. So just knowing in advance what your provider does or does not do can be helpful. It can also be helpful if you're planning a home birth or a freestanding birth center birth to talk with your midwife about ways they like to encourage labor to get started if you're wanting to go into labor sooner rather than later. And there can be reasons for that as well, right? In some states, midwives cannot legally attend home births after a certain gestational period, so there might be some real incentives to get labor started. So that's my, and if anybody has any thoughts in the chat, you're welcome to share. Yeah, rotating call. Somebody says we have rotating call. We don't do elective inductions. You show people the induction involves the balloon and what has to be done to dilate or ripen your cervix. It can, yeah, with informed consent, people might still choose not to do it. And another thing that we didn't really talk about, we're not going to cover, is the whole area of research on outpatient inductions. In some countries, that's becoming the standard where you do a large part of the induction outpatient, which I think is really interesting. There's actually Cochrane reviews on that. You can just do a PubMed search for outpatient labor induction and find a whole bunch of research. I'm not going to go in that tonight, though. That's a whole different rabbit hole. Okay. So let's talk about preeclampsia. So we're not going to go into depth about high blood pressure and preeclampsia, but one of the things that struck me about the ARRIVE trial was they had such a high rate of preeclampsia and hypertension. So what was the deal with that?
Yeah, that is a great question. And like you said, kind of has come up with people who have reviewed the study commenting on that. And so, just to remind folks, around 9% of the people who were induced at 39 weeks in the ARRIVE trial had a hypertensive disorder of pregnancy. So, like gestational hypertension or eclampsia. And that was compared to around 14% in the expectant management group. And so people noted that this was high because this sample was supposed to be kind of like low risk pregnant people. And those rates are actually like higher, especially at that time, than what you would see sort of in the general population. And we really don't know why that might be because we don't really have enough information from the study and on the participants. So, like in one critique, I saw that the author said it would have been helpful to know how the people who chose to participate in the study, like at the study sites at the 41 hospitals who participated, compared to like the people who chose not to participate. Like, was there something kind of different about the people that chose to participate in the study versus those that didn't? And of course, you can't really collect data from people who choose not to participate in the study, but just to kind of compare like how their health outcomes were different. And they also said it would have been interesting to know whether some of the ARRIVE trial outcomes, like cesarean birth, were different, like higher or lower among the birthing people in the study who didn't develop hypertension. So, kind of, they call that like sort of a stratified analysis too. And we haven't really seen that. And I also do want to note, though, that since the ARRIVE trial was conducted back in 2018, rates of gestational hypertension have like continued to go up in the US. So in 2019, 13% of pregnant people delivering in hospitals were diagnosed with a hypertensive disorder of pregnancy. And that was compared to like 11% in 2017. And we don't really know why for certain, like no one can definitively say why this is, but some researchers speculate it's because we're also seeing increases in some of the things that, increase the risk for gestational hypertension, like more birthing people giving birth at older ages, who might have higher BMIs, and more who are diabetic giving birth as well.
Hmm, interesting. We have had a request from Team EBB to cover preeclampsia at the fall webinar. So we do have a training on high blood pressure and evidence-based care in pregnancy, and that is in the pro membership. But we're thinking about doing we've had a request. So if you want to put your name in the hat for like say yes, please, not for you to teach it, but that you want us to do it, tell us. As you can see, our team EBB, Jen, Shante, they say the people want it. So okay. One more question for you, Morgan. How long was the average or median induction length in the Arrive trial? Because I mentioned inductions can take 2 to 3 days. So what was the average?
Yes, that's also a great question. So the median length of stay during labor, or of the labor on the labor and delivery unit, for those who were induced was about 20 hours. And I think they give that range of like 13 to 28 hours. And that's compared to the median length of stay in the expectant management group that was 14 hours. So 14 hours versus 20 hours were like the median sort of range. And in that range in the expectant management group was 9 to 20 hours. So
Okay.
yeah, about
It
20
feels like it's
hours.
weird. That
Mhm.
range seems low to me, like because I've known so many people have gone to 48 or even 72 hours with an induction.
Mhm.
And people were saying, oh, induction outpatient sounds dangerous, but most of the time induction outpatient is the cervical ripening part, which can take a really long time if it's your first baby. Do you have a question picked out you want to ask me?
I don't know. Should we tackle kind of the ones around sort of due dates and like how long a pregnancy is and sort of that
Yeah,
impact?
let me do that briefly because we do have a whole signature article on that. So a lot of people are like, well, you're inducing at 39 weeks. Is that even accurate? Is there a due date for your baby? And so at EBB, we have a signature article. I'll have our team drop the link. We actually have two. One is ebbirth.com/due dates, and that describes the whole concept of a due date and how accurate it is or inaccurate. And the best way to date pregnancies, which is actually an early pregnancy ultrasound along with your LMP, your last menstrual period. And it seems that the typical pregnancy that's not induced is about 40 weeks and 5 days if it's your first pregnancy, and 40 weeks and 3 days if it's a subsequent pregnancy. So as you can see with the Arrive trial, affects a lot of people because about half of people don't even go into labor until 40 weeks and 5 days with their first pregnancy. So I think the rate of spontaneous labor by 39 weeks, if you haven't had a preterm birth, it's like 10%. So we're talking about a huge, like most people who are pregnant will be, if their provider is recommending an induction, will be recommended either an elective or a medically indicated induction. So we have two peer-reviewed articles on, one for due dates and one for inducing for your due date. And the inducing for due dates article is really important because it goes over all of the risks of stillbirth, all of the risk factors for stillbirth, and induction benefits versus risks at different points in pregnancy. So tonight we're specifically focusing on the 39-week induction, but that article goes into more depth about 40, 41-week, and 42-week inductions. So hopefully that is helpful. What's next? So could you talk about the standardization of induction methods used in the Arrive trial? Like what were the methods that they used? They managed to achieve a 19% cesarean rate with inductions of first time moms. So what did they do?
Yeah, so I was able to find this information. I pulled it directly from kind of one of the supplementary materials that the authors published with the study. So just kind of like reading what they did. And yeah, it was in their study protocol. And so this is what they kind of recommended that providers participating in the study do. So for those with a favorable cervix, so like a soft cervix, it's like ready for labor, and there's like Bishop scores and stuff like that. But for those with a favorable cervix, they were given oxytocin. For those with an unfavorable cervix who had a Bishop score of less than 5, they had to first undergo cervical ripening along with or followed by oxytocin. And so the method of cervical ripening was left up to the individual healthcare provider. They didn't really stipulate or recommend one method over the other. They did expect that the baby's heart rate would be monitored throughout induction or labor, either continuous or intermittent fetal monitoring. So that's where they either listen to the heart, like there's a heart monitor kind of strapped on the birthing person all the time, or it's like checked periodically. And patients were also expected to stay in the hospital from the time the induction or ripening began until birth. So like none of that sort of outpatient situation. And then per the ARRIVE trial protocol, it was suggested to healthcare providers that birthing people be allowed at least 12 hours in sort of the latent phase of labor after any cervical ripening or rupture of membranes or oxytocin was used before they would be diagnosed with a failed induction and a cesarean would be ordered. And so we do think that a lot of providers sort of adhered to those sort of recommendations and guidelines, again, because they were able to get an unusually low cesarean rate for first-time birthing people compared to what we sort of see in other hospitals around the U.S.
Yeah. With the post-arrive studies, I think it's interesting. Somebody was pointing it out, like, why aren't we just recommending birth centers and home births if you're trying to decrease the cesarean rate? And I think that it's important to point out that there was a motive behind this study. If you go listen to presentations that the authors did before the study was published, when they were explaining why and how they were doing the study, they wanted to show that 39-week induction was effective because they were already using it. So the whole motivation for this study was to kind of confirm their pre-existing beliefs, which is not the best way to design or carry out a study because it can introduce bias, such as we talk about in the videos, the Hawthorne effect, where they knew they were being watched. They wanted to find a specific result, so they could have worked extra hard to try and keep the cesarean rate lower in the one group. They were not blinded, so they knew which patients were in which arm of the study. So I think you have to remember this is coming from the medical model of care, not the midwifery model of care. And in fact, there were very few midwives participating in this study. So almost everybody had obstetrician led care. And in the post arrive studies, they haven't even looked at the effects of doulas or midwives in terms of, like, because exactly, this is when the ARRIVE trial came out. People were freaking out. I remember in 2018, it was right before it came out. Everybody was like, oh no, what are they going to find? They're going to show they're going to use this to tell everybody they need to be induced. And I went and looked at the study, and I published a blog article before the results were even out, just explaining how they did the study so that people would understand it. And I said from the very beginning, like, you don't have to induce to lower your chance of cesarean. There's so many options. This is just like one option, and it only lowers your risk a little bit. It's way more effective to just have a doula present at every birth. If they really wanted to lower the cesarean rate and were serious about it, and they bill a lot for these inductions. So you can't say that the doula is too expensive. Speaking of cost, Morgan, can you talk briefly about that?
Yes, I can, because that is another sort of hot topic in question. Because again, that was one of the motivations, is that induction could be more cost effective. And the research is kind of mixed on this. And it really comes down to and is sort of dependent upon the cesarean rates that we actually end up seeing in people who are induced. So as long as the cesarean rates end up being lower in the induced sort of folks who are induced versus those whose pregnancies or births are expectantly managed, then it can be more cost effective. But if you kind of look down how sort of costs break down through like labor and delivery and postpartum, labor and delivery costs do appear to be higher for people with elective inductions because they often do spend much more time in labor and they often need more interventions. But their postpartum costs, might be lower, again, really dependent upon that cesarean situation. So if they're less likely to have a cesarean and then less likely to be in the hospital for as long as postpartum, then those costs will be lowered. But there were a few specific studies I can just kind of talk about briefly. So in one of them, researchers used like a cohort of around 1.6 million births, sort of a theoretical cohort, and they pulled like outcomes based on actual data and statistics from the CDC. And they were able to sort of predict the likelihood of all the different outcomes that the ARRIVE trial looked at. And they found that induction did have higher costs, but it increased something that we call quality adjusted life years, which is kind of a measure of how well different kinds of medical treatments like improve and lengthen patients' lives. And so based on that, they said it could be considered cost effective, but it was only cost effective about 65% of the time. And that cost effectiveness was really dependent upon the cost of the induction. And again, that cesarean birth rate. So they found that if this was back in 2019 when the study was published, and they found that if the cost of elective inductions were to increase by $180, it would no longer be cost effective. And I'm not sure where they like pulled their prices, because I know prices are kind of proprietary and hospitals don't openly share a lot of that data. But they said if they went up by $180, they wouldn't really be cost effective anymore. They also wouldn't be cost effective if the cesarean rate among those who were induced was 22%, which was the rate that we saw in the expectant management group in the ARRIVE trial. So if that cesarean rate again went up and like sort of met the 22% of the expectant management group, no longer cost effective.
Mhm.
And then there
I
was like
think that,
a
yeah, the this is where I think the problem is, because you can't generalize these results from the ARRIVE trial to every hospital, because there are plenty of hospitals that with an induction you could easily have a 40% cesarean rate if the providers are not using correct evidence-based methods of preventing failed inductions. So when you said cost effective, that was for just the healthcare system in general, correct?
Mhm. Yes, yeah, correct.
Not for the patients.
Um, yeah, and there was like another study that used there. It was actually 5 hospitals in Utah that participated in the ARRIVE trial, and they looked at their like actual cost data, and they had it for around I think 1,200 people, and 600 ish who were induced, and 600 ish who had expectant management, and that included the total cost of maternal and newborn care from the time the patients like were randomized into the study through 8 weeks postpartum, and they found that maternal outpatient costs were lower among those who were induced, but their inpatient, again, those delivery and care costs that happened during sort of the labor and birth were higher. And they also kind of did some analyses looking at, maternal age and pregnancy BMI and the need for cervical ripening. And they weren't really different. So the total cost wasn't different between the two. So it doesn't appear to really reduce costs, and can again increase costs in some ways.
It does. I don't know if any of you have seen this in the chat here, but one thing I have seen is that some hospitals are so full with people getting 39-week inductions that it can delay medically necessary inductions. Or pro members were telling me that sometimes parents are really confused because their doctors are saying, hey, it's really important that you have this induction to lower the risk of stillbirth at 39 weeks. And then 39 weeks, and every day their induction is pushed back for like a week because the hospital is so full of inductions that they can't get in. And then the parents are like, why can't I have my induction? You said that I needed this for my baby. And it's really confusing. So I don't know if anybody is seeing that play out in their hospital. Okay. People in the chat are saying yes. Our L&D floor is bursting at the seams with inductions, patients upset for being delayed. Yeah. Labor intensive care, high use of resources. And there was a shortage of oxytocin in the United States last year. And it was interesting to see like whether or not the inductions would be kind of pushed back. And again, you have this whole field telling patients you must have this because it's what's safest. And then we can't provide it to you. Sorry, but it's not necessary. So you're okay. It's just very confusing. I wonder if we have time for a couple more questions. Is there one in particular you think we should? Oh, can you do, Morgan, the breastfeeding and epidurals? Because a lot of people are mentioning that, they're curious, are these inductions affecting breastfeeding rates or epidural rates, things like that, or
Yeah,
postpartum?
we had a few questions of people asking about different sort of postpartum outcomes and different things with that. So we do typically see more epidurals among birthing people who are induced, and some studies have also shown that they opt for an epidural earlier in labor compared to those who aren't induced. And speculation on why that might be is because of the higher pain that is often attributed to medically induced contractions with that like synthetic oxytocin. And the ARRIVE trial did look at some of these like other sort of maternal health factors, like perinatal tears, infection of the placenta, and amniotic fluid. Postpartum hemorrhage was another question that people had a lot. Did that increase? They didn't find any differences between the two groups and sort of any of those like birthing people sort of focused outcomes. There were a few other studies that were done. One study that looked at, which we actually featured in the videos, looked at births pre and post arrive, and they found that birthing people in the post arrive were more likely to need a blood transfusion and to be admitted to the maternal ICU. But blood transfusions were already on the rise prior to the publication of the ARRIVE trial, and that study didn't really differentiate between births that were induced and not. They just kind of looked at pre and post arrive. But regarding breastfeeding, there is some research that suggests that inductions reduce the likelihood that a birthing person will breast or chest feed or do so for the recommended length of time, which is about 6 months exclusively is what's recommended. So there was a pretty big study that was done in Australia that had about 600,000 people, and they found that synthetic oxytocin use, like is often used in inductions, was associated with an increased odds in the use of formula in the hospital and decreased odds of exclusive breastfeeding at 3 and 6 months postpartum. And they also found that like the more interventions someone experienced during their labor and birth, then those sort of outcomes were even worse. Like they were even less likely to initiate breastfeeding in the hospital or less likely to be exclusively breastfeeding at 3 and 6 months out. And then there's kind of a question that was related to this, Dr. Dekker. I don't know if you want to like touch on it now, but about sort of maternal satisfaction and people's birthing experiences is something being looked at. So I don't know if we
Yeah,
want
go
to.
ahead.
Oh
Yeah.
yeah. So that isn't something, and that also came up during the pro membership webinar too, is birthing people's like satisfaction hasn't really been measured that I've seen in the research. And that also, something to consider is, people's experiences of autonomy and respect during their birth hasn't come up, or like ties to postpartum mental health. And we can kind of see how those things might be impacted if people are reporting pressure to be induced. The ARRIVE trial didn't measure maternal satisfaction, but I do want to mention that they measured pain levels and people's experiences of control, like their perception of their control during their birth, using this something called the labor agency scale. So I didn't want to like not say that, because if people were to read it, you would see that come up.
But that's not the
Um,
best way to measure. It doesn't measure satisfaction, and that tool
exactly.
isn't that great at measuring control, feelings of control.
Exactly. And the scores, the median scores, like were barely different between the two groups. And they think that even the difference that they saw could have just been because the study was so large. It had like enough people to kind of detect what we call a statistically significant difference. So no, we haven't really seen much done on birthing people's actual satisfaction with their birth and their experience of their birth based on elective inductions.
Yeah, that's really helpful. I'm going to briefly just let everybody know that we do have EBB articles and podcasts on big babies. That's in the signature article directory. So if you have a question about preventing shoulder dystocia, that would be answered in that article. People are asking about advanced maternal age, and we have an article about induction for being 35 and older. And people are asking about postpartum hemorrhage. We have an article on that as well. It's like the evidence-based birth article on Pitocin in the third stage, but it focuses on everything related to bleeding postpartum. So that is also in that directory.
Yeah, so someone commented that they're seeing most of their IVF and advanced maternal age clients being offered or pressured on induction. And that's something that we've heard a lot as well. So I looked into the IVF stuff a little bit earlier, and the recommendation to be induced at 39 weeks for IVF probably comes from the increased risks associated with IVF for some complications and issues like placental abruption and cesarean delivery and stillbirth. But those risks, I do want to say again, that absolute risk is pretty small for some of those outcomes. And they're typically higher when someone is pregnant with multiple babies, which can happen with IVF versus one baby. And because of those risks, that's why you'll see some providers recommending an induction. And we do see higher rates of induction in studies comparing people who have IVF to those with spontaneous or non IVF pregnancies. But as of 2022, the Society for Maternal Fetal Medicine, SMFM, you'll see it, states that it isn't currently known whether elective delivery at 39 weeks reduces the risk of maternal death and health issues in babies for IVF pregnancies compared to expected management. So they can't say definitively that induction should be done for people with IVF. They recommend instead shared decision making between birthing people and their doctors when considering elective induction at 39 weeks as an option. So again,
Wow.
leaving that decision between the birthing person and their doctor.
That's new because, yeah, thank you for sharing that, Morgan, because in the
Mhm.
AMA article, we didn't, last time we looked that up, we didn't have that statement. There actually really wasn't any guidance at all from the professional organizations. That's interesting that they state it's not known if it's helpful. And so they just recommend having a shared decision making conversation. That's
Right. And
coming from
for
the Society for Maternal Fetal Medicine in the United States. Those are the high risk obstetricians.
mhm. And so for advanced maternal age, there's some research that compares that too. And again, IVF is also kind of associated with like advanced maternal age to people that are advanced maternal age is like older than 35. More of them tend to be able be like IVF pregnancies as well. And like there, it's kind of like a weak recommendation that induction at 39 weeks for birthing people who are at least 35 years of age but also taking into consideration like fetal and maternal monitoring and the patient preference. So again, that sort of shared decision making
Mhm.
piece is important there. And again, no, nothing that's saying definitively like this must be a thing that people do, but should be something considered to reduce risks of potential health issues.
All right. I think my last question is just, and we can crowdsource this a little bit if you want. There's so many doulas in the room. So, what are some strategies that doulas can use to help their clients if their clients are just continuously experiencing this talk about the 39-week induction with their provider? So, Sasha says prepare them ahead of time that they will face this. Molly says, ask the what would it look like question. So, like, what would an induction look like for you versus what would spontaneous labor? Ask why. Refer them to EBB. Sing the boundary song. Oh, we need someone to sing that for us. I don't know if I know that. Using the brain or brand acronyms, which most birth workers are familiar with. Ask why this is relevant for me as an individual and my baby. What is the diagnosis for it? Bring it up during your prenatal appointments as a doula because it's one of the biggest things that happens to your clients. Ask your provider in advance at what point do you recommend an induction and why? Asking what are my risk factors, not just for generalizing me as part of a large group. Teach them they have rights to their body and their autonomy. Take a doula with you to your late term appointments. That's great. I was just at a Kansas City birth worker conference, and there were several maternal fetal medicine and obstetrician doctors in the room. And one of them said, I love it when when doulas come with their clients to their prenatal visit because then I can meet them and we can build a rapport. So that was really cool.